I think hopefully we'll have more and more submissions, and we'll be able to get a PubMed index journal from our own society front way. And we also this month, next month, I think December 11th, I think we have our first anniversary of one of our patrons who passed away, Professor Balasubramaniam. I think we won't be meeting next month, so in fond remembrance of his memory, I think he will also be happy to know that we have made progress with the GHub journal as well. So moving on to the next part will be the CME. I request chairpersons Dr. P. Ganesh and Dr. M. Malarali to conduct the proceedings. Interestingly, we also have an international guest who has come over here from the US, Dr. Bharat, who has also joined us from the US for our meeting. I welcome him here as well, sir. Thank you. The chairpersons, please. Yeah.
We'll start off with the next session. We're going to have a talk on PET-CT and theranostics in net tumors by Dr. Indrani. I have great pleasure in introducing Dr. Indrani. She's a senior consultant in nuclear medicine, diagnosis therapy. Good afternoon, ma'am. And PET-CT at Apollo Hospitals, Chennai. She passed out from Stanley Medical College. She did a DIP&B radiology and DIP&B nuclear medicine from Apollo. She is the president-elect and past general secretary of the Association of Nuclear Medicine Physicians of India. She has contributed chapters in textbooks of medicine and atlas of nuclear medicine. She has published in many national and international journals. I invite Dr. Indrani to give a talk.
Today, this talk is about PET-CT and theranostics in gastroenteropancreatic neuroendocrine tumors. So as we all know, I'm not going to talk much about the clinical aspect of it. I'll stick more to the nuclear medicine aspect. So this is a more indolent tumor. And gastroenteropancreatic neuroendocrine tumors almost forms a major part of it, 58%. And recently there has been an increase in the neuroendocrine tumor incidence. Is it because it was rare or we underdiagnosed it? And regarding the functioning and non-functioning neuroendocrine tumors, whether it is functioning or non-functioning, the beauty of the somatostatin receptor imaging is that it is going to pick it up. Even in non-functioning tumor, it is going to be positive. And the major challenge in the neuroendocrine tumor diagnosis is the delay, because sometimes even some of our patients, they lose almost about 6 months before getting it diagnosed. And our work starts after the availability of pathology. So according to the WHO classification, the recent 2019 and the recent modification of 2021, the nomenclature has been changed from neuroendocrine tumor to neuroendocrine neoplasms. The role of somatostatin receptor is mainly in the well-differentiated ones. The well-differentiated one depends on the KI index, less than 2, and grade 2 is 2 or 3 to 20. Grade 3 is more than 20 KI index. And then poorly differentiated, it is more than 55. And the grade 3 itself, the terminology differs according to well-differentiated or poorly differentiated as neuroendocrine tumors or neuroendocrine carcinomas. So there are circulating tumor markers, this chromogranin A. I will just tell the practical points. There are some patients who come alerted with increased chromogranin A. They want to come and have a somatostatin receptor. And here we have to remember the PPIs can increase the chromogranin A. So it would be better if they can stop it at least for a month and then come for the scan. And there are very, very VIPs who get very alerted about it and come and ask for a somatostatin receptor scan to make sure that they don't have a disease. We have done in that occasion just to say that there is nothing. So it gives a very high negative predictive value also. So there are conventional biomarkers like synaptophysin chromogranin, and here what we are using is mainly the somatostatin receptors. So once the somatostatin receptors are there, that is going to be detected by the gallium-68 DOTA PET-CT. So coming to the nuclear medicine aspect of it, there are somatostatin analogs which we are diagnosing with the gallium-68 DOTA, and the catecholamiine analogs and metabolites with F18 DOPA, and then glucose analog F18 FDG, GLP receptor agonist gallium-68 hexandine, and I would like to also add one more in the name of gallium trihexane. So these receptors are expressed on the cell surface. So what is the basic representation is that the receptor, that is the link up, one peptide, the linker is the DOTA, and we use the radionuclide. This is the basic principle. So that is why it is called peptide receptor radionuclide therapy when it comes to PRRT. So gallium is the radionuclide, bifunctional chelating agent is the DOTA, TOC, NOC or TATE is the peptide, and we try to image the SSTR receptor by this combined target. So gallium totatate is used for diagnosis. When the scan is positive, for the therapy, lutetium is used. So the lutetium gives the radiation to the tumor. This is just for, I included these slides for the PG's purpose, because quite often we get a question whether it is a SPECT-CT, PET-CT, what is a SPECT-CT, like that. Just to make it clear, this is basically a fusion imaging, unlike CT or MRI where it is an anatomical imaging. This is a functional fusion imaging where CT and functional part of it, PET or SPECT, is combined. This is basically what is the difference between them. The CT and CT is a transmission scan, whereas this nuclear scans are emission scan. That is, the radiation is coming from the patient's body. The injectable is injected and then it comes from the patient's body. That is scan. So it is an emission scan. The difference between the SPECT-CT and PET-CT is this. SPECT-CT is mainly for the energy around 140 kV, whereas technetium-like radioisotopes are used. Whereas for the PET-CT, the energy is very high, 511 kV, so where the PET is used. Well, what is the use of knowing these two? The PET is used for diagnosis, post-treatment with the lutetium. The SPECT is used for seeing what has been injected and what has received. So post-therapy scan is done. Lutetium post-therapy scan is done with the SPECT-CT. It's just the gallium DOTA, there's a typo. Gallium DOTA is injected intravenously. We have to give some time for the uptake of the medicine. Then the image the patient first with the CT, fast run of the CT, then do a PET aspect, each step from the head to toe, and then we combine these two to produce a gallium DOTA PET-CT. And what are the differences? Because quite often you think, what is this DOTA and what is a TOC, NOC, TATE, like that. This is nothing but this gallium is the same, nucleide is the same, linker is the same. The peptide, that has a small difference in their expression. So the TOC is mainly for the SSTR receptors of 2 and 5, and NOC is for 2, 3, 5, and TATE is for SSTR2. The SSTR2 is the one which is maximally expressed on the neuroendocrine tumors. So this is nothing but we are imaging the peptide which is injected into the body, and we are imaging the cancer cells. So what is the normal distribution of gallium-68? So unlike, how do we differentiate between an FDG scan and a gallium scan? In an FDG scan, we can see very bright activity in the brain, whereas in the gallium scan, this is not there. So that is one main differentiating point to know how to differentiate. And this is the normal distribution. We can see both kidneys, the liver, spleen, and bladder. That is what is shown in the fusion imaging. This is called maximum intensity projection image. So I'm just showing some of the images. This is a net of pancreas with the liver metastasis and skeletal metastasis. So don't be happy when you are finding only one primary. You have to look for the other primary also. So you can have a 2 primary, one in colon or one in ileum, like that. So coming to the very small duodenal polypoid lesion, often we get reference for one small polyp taken off by the duodenal endoscopy, and that comes as carcinoid or neuroendocrine tumor. So what is the status? Is there any other lesion or is there any other tumors in the whole body? Then in that case, we often even 0.5 to 1 centimeter we detect. This is another one which is there. Either happens like this, or one tumor is removed, we may not have anything. This is for assurance that rest of the body or rest of the intestines are not having any other lesions. There the use of gallium dotanarc PET CT goes. So this is the point to stress here. The CT is negative, but we have positivity in the functional imaging, and sometimes even beyond the PET CT imaging, PET MR imaging is more useful to detect even minute lesions which cannot be even detected in CT. So these functional images detects the metastasis much earlier than the anatomical representation of a metastasis. So this is to know about the flip-flop phenomenon. Like, what is it? It is nothing but when it is well differentiated, the somatostatin receptors are highly presented. When it goes for a de-differentiation, the more GLUT receptors are expressed, so therein FDG PET CT comes for a role. So there is a well differentiated expression and a poorly differentiated expression. In between you have a gray zone where both can be expressed and how to deal with it. This is called inverse flip-flop phenomenon, where FDG is more and SSTR, that is gallium, is less. So this is to just represent, so axial PET CT, this is negative, gallium positive. Whereas in this, the FDG is positive and SSTR expression is less. So this is an example of small bowel carcinoid with a liver metastasis. This is one of our first patient where he was told like he's going to die in 6 months, but then when he came to us, we found the primary as well as we imaged the secondaries, and this was done in 2012, and we gave our first gallium lutetium therapy in the year of 2014, and the patient happens to live even in the year of 2023. This is an example to show the MEN1 syndrome. You can see both adrenal and bilateral, parathyroid adenoma, pituitary tumor, all were there. Apart from that, peritoneal deposits also were there. This patient also received therapy. This is an example to show where gallium-68 Isgtnc is used. It is used for identifying insulinomas, that is, it is called beta cell imaging. We have used it even after pancreatic transplant to know whether the cells are viable or whether it is functioning. The same can be done with this. This, as I said earlier, even the 0.5 centimeter tumor also can be detected because we have both CT in 3-phase arterial, venous and delayed, as well as functional imaging with the Isgtnc. This is for insulinoma. Coming to the trihexane, as I have told you, this is FDG negative. It is a carcinoma of pancreas where FDG is negative. The integrin, the trihexane is nothing but cancer integrin alpha V beta 6 imaging for the carcinoma of pancreas where you see the uptake. That is what is represented in the fusion imaging, and this can also be used for the head and neck CAs. Here you can see the arrow mark showing FDG negative but integrin positive tumor, and the same integrin can be used for the treatment therapy aspect of it. This is an F18 dopa PET CT for hyperinsulinism in the pediatric patient. And coming to the therapy, so far what I have talked is about diagnostics. What is theranostics? The topic today is PET CT and theranostics. The theranostics is nothing but the combination of diagnostic and therapy. Theranostics, the theranostics. Gallium we image, diagnose. Lutetium we treat. So it is a theranostic pair. Like that we have pairs where diagnose. Even radioactive iodine is one of the earliest theranostics that was started. And like this we have for other radiopharmaceuticals as well, including integrin. So what is a targeted therapy? This is actually a targeted therapy. What we are doing, lutetium, is the targeted therapy. Instead of blindly shooting everywhere, we shoot only the cancer cells. That is what is peptide receptor radionuclide therapy. So it is a, like you see before treating what you are going to treat. So treat what you are seeing, and after treating you take the post-therapy scan in the form of lutetium post-therapy scan to know what you have treated, whether it is already gone there, and giving the treatment. So what are the advantages of this PRRT? It is highly targeted, as I explained, and it has excellent tolerability, unlike chemotherapy, with a minimal toxicity profile, and it has a convenient treatment scheduling, like one cycle. It's a day care procedure in a gap of 8 to 12 weeks, and we can give up to 6, and then we can give a gap and just maintain, and then when needed we can do it again. So what is the role actually? So it is actually a ray of hope for patients who have depleted all the options and they don't have any other option. Then go think of this PRRT. And in PRRT, we now also have actinium-225. We have treated. I'll show you some of the examples of this as well. So we have got the global approval for this PRRT in the year of 2018, but we are more European standards, so we in our hospital itself started using this in the year of right from 2014, and almost every week we have patients for the same. So what is that like? I said it is mainly for grade 1 and grade 2 tumor, but then when we want to broaden the use of therapy, we can use up to the 20 to 50 Ki also. And according to the ESMO clinical practice guideline, it can be updated up to 30. And this can be combined with even long-acting octreotide as well as chemotherapy in between the 2 cycles. So this is mainly to show that what is a clinical setting and potential considerations, as I have said, mainly for the advanced metastatic inoperable and progressive NET grade 1 and 2, and what are the potential consideration, extensive diseases and symptomatic functioning tumors uncontrolled by the SSA. So what are the use of this PRRT beyond the JEP-NETs is it can be used in any of these neuroendocrine tumors apart from JEP. So what is the response assessment after this therapy? The symptomatic treatment and symptomatic improvement is really excellent. First, when they come bedridden, after giving even 1 cycle, they get up and sit and even walk and come. So symptomatic relief and quality of life is really very appreciable. We see it in every day-to-day practice. So the biochemical response is up to 60 to 70%. The radiological response is 70 to 80%. The stable disease is 60%. Complete response we attain only in the 2 to 6. But even non-progressing stable disease without new lesion is considered to be a good therapy. And only the partial responses in around 30% of the patients. So these are the classical indications, as I have already told. And there is something called Krenning score before we take the patients for the therapy. These are the like how well differentiated and poorly differentiated. For poorly differentiated, you go for the chemotherapy. For the well differentiated, looking into all these considerations, we go in for the peptide receptor radionuclide therapy. So how do we decide whether the patient is going to benefit from the lutetium or not? So you see look out for the somatostatin receptor status. Do a scan, diagnostic imaging with gallium-68 DOTA. If the tumor is positive, expressing the somatostatin receptors, you can go in for the lutetium therapy. Whereas if it is negative for the somatostatin receptor, you have to go for the conventional therapy. So what is this Krenning score? This is nothing but before going in for the therapy, you have to make sure the uptake of the DOTA by the tumor cells are much more than the liver uptake itself. That is what is shown here. 3 and 4 are the optimal uptake which can go in for the therapy. Whereas no uptake, very low uptake, less than liver is like either you have to go in for the further investigation and further therapy in additional. These are the ones that is expected for before going in for the therapy. And this is to show this is a pre-therapy gallium, this is a post-therapy gallium. That is after 2 two treatments, see the nets, almost the expression is totally gone. And this is what I was telling about post-therapy DOTA lutetium scan. This is done with the SPECT CT to see after this treatment, this was taken to see that the lesions have gone. There will be always a difference between the PET CT and SPECT CT because this is very high energy, so the lesions what you are going to see will be very clear with clear sharp edges. Whereas in the SPECT, the energy what we are using is we are trying to use the, what all these therapies are beta therapies. So here we are using the very little gamma that is coming from the lutetium for imaging purpose to make sure that the lesions have taken up the. This is to show again therapy response. You see the chromogranin, the levels have come down significantly, but there are no tumors. If you don't have any new additional tumors, that itself is considered to be a very good response. This is to show the difference between the gallium and FDG PET-CT. Here you can see with the treatment baseline and after 3 cycles how much it is reduced. The same with the FDG to see when you have a mixed tumor which expresses both, you have to do both the scans. So you see it is reduced, but for the primary in the pancreas. So this is after all the metastatic lesions have gone, you have to consider, that is, you can say before surgery, you can do all these treatments, reduce the functioning aspect of it, then remove the primary. So there are many trials which are available on this lutetium's usefulness and therapy and everything. First major one of them is the NETTER trial, which used it mainly for the midgut, and they have set excellent response on all the reduction in the death by 79%, excellent quality of life, and then progression-free survival also increased. And coming to the NETTER 2 trial, so NETTER 1 trial was very successful. So what are we going to do about the grade 2 and 3 tumors? How is it going to be useful in combination or alone? This is again tried, and here again with this numbers of 222 patients, they have found it to be very useful, and that has been published as well. So for the PG sake, there is something called PET net score. What is this PET net score? This is nothing but from P0 to P5. This is to say whether the somatostatin expression is more or glued receptors are more. Which one is going to be more useful when you are going to do the therapy? So we want more somatostatin receptor for the therapy with the lutetium. For if you have more mixed combination of P3, so that means it has both the receptors. You can do both lutetium and alter it with the chemotherapy in between. And when it is only P5, when more of FDG, then you have to go for more conventional treatments. This is to show an example of what happened after actinium-225 dotatate therapy. This is a young girl, about a college student, about 19 years when she came, and she received multiple lutetium therapies, and after that she went for a actinium-225 dotatate therapy, where after the treatment, with one single treatment, you can see much of her symptoms, all the symptoms, that carcinoid symptoms that she had, reduced very, very significantly, and her tumor burden also reduced. And what is this alpha emitters when you are using a lutetium as a beta emitters? Alpha emitters are nothing but beta emitters are doing a single strand DNA break, whereas alpha emitters do a double strand DNA break. So the efficiency of the alpha, but because their linear energy transfer to the cells are much more, so they are even more, 50 times more potent than the beta emitters. So that is what is the role of alpha, but it is yet to get a FDA approval, as well as this is used as a kind of palliative end-of-life therapy even without FDA, that is special permission is got for that and done. So because this is a gastroenterology group, I would also want to just put in a word about that FAPI. FAPI is theranostics with FAPI also can be done. These cancer-associated fibroblasts, they are more in the stroma. They express something called fibroblast activation protein that can be inhibited with lutetium FAPI therapy. So this is used mainly for the epithelial carcinomas. These are the fibroblasts, these are the tumors. This has effects in 3 different ways. One is that it goes into the fibroblast and they destroy them, and by being nearer to the tumor cells, they give cross radiation, as well as after giving the treatment, this fibroblasts, they die, and then they give more space for the other medicines to go get inside. So the chemotherapy's efficiency will be much more after giving this treatment. And this is to just express where all the FAPI is used. These many cancers where the FAPI can be used in gastroenterology, in neuroendocrine tumors also this can be used. And wherein even HIPEC failed, we can use the intra-abdominal FAPI, and you can see the difference after the first dose of actinium, you can see the response. Just to finish it, there is also liver-directed therapies where yttrium spheres are administered in the radioembolization, and it mostly for the NET with secondaries confined to the liver. So thank you. The take-home message is that nuclear medicine has something for the JEP-NETs in the form of theranostics. The theranostics is the name that we have to just remember. That is it. Thank you.
So we'll go to the next topic, the panel discussion. The panelists will be introduced by Dr. Malharvari.
As Madam has told, in our understanding from carcinoid to neuroendocrine tumors, now the nomenclature has changed to neuroendocrine neoplasm. So is the approach and treatment. So it requires a multidisciplinary approach, and rightly we have formed a panelist which constitutes a clinician endoscopist, a gastroenterologist, a pathologist, a radiologist in nuclear medicine, and a medical oncologist. So the next topic will be the panel discussion. I'll call the panelist Dr. M.N. Saravanan, surgical gastroenterologist from Apollo Proton. I request you to occupy the chair, sir. Dr. Indrani ma'am, she's already given a lecture. And Dr. Vinod Kumar, a senior consultant, Department of Medical GE, GEM Hospital. Dr. K. Sivasubramaniam, senior consultant, Department of Medical Oncology, SMF. And Dr. K. Shushridan, senior consultant, the Department of Pathology from SRMC. To moderate this session, I call upon Dr. Satyamurthy, a senior consultant, MedIndia Hospital.
Very good evening to one and all. I am Dr. Satyamurthy, consultant gastroenterologist from MedIndia Hospitals. I thank, at the outset, I thank Dr. Paramanayan sir for giving me the opportunity to moderate this session on management of NETs. And very good evening to the chairpersons and the panelists here. So we have formed a good panel to discuss. So as already Madam has discussed the last part where we sent the patient when nothing is possible. So before that, as a gastroenterologist, we should know how to diagnose an NET. The panel discussion I will conduct like this. First, as a gastroenterologist and endoscopist, what are all the parameters to be checked, and what is the role of the biomarkers and endoscopic biopsy techniques, and this is the most common duodenal NETs, how its presentations and when to intervene, all these things. So I welcome all the panelists. So first, an audience question. To help, I have a pathology slide also here. So these are the common subepithelial lesions we encounter during our endoscopy. These are all the subepithelial lesions we encounter. How many NETs are there, or which is an NET? So are we confident in diagnosing an NET by endoscopy? The first panel. Very good. Brenner gland hyperplasia is the first one. So the second one could be a suspected NET. neuroendocrine tumor with the smooth overlying mucosa. And the third one, very good, lipoma. And fourth one is a stromal tumor, GIST. We have so endoscopy alone is not sufficient, but histology. So this is what we are going to discuss now, the NETs. So as introduction has already been discussed by Madam, these NETs are being reported very common now because of the increased endoscopy screening procedures like colorectal cancer screening. The newer terminology, as Madam said, it is a gastroenteropancreatic neuroendocrine neoplasms, which encompasses all the GIT and the pancreatic NETs. Now it has been considered the second most common prevalent digestive cancer after the colorectal cancer. But if you see the overall survival rate, it's better when it is detected early, when it is a localized disease. Overall survival rate, 5-year survival rate is 94%. When it is localized, it is 97%, with distant metastasis up to 70%. The survival depends on the stage of the tumor, the grade of the tumor, and the site, and the age, and the general condition, and the treatment response. So we have a sporadic tumors and inherited syndromes, and mostly they are asymptomatic in the early stages, which are instantly detected during the endoscopic screening. And we have a functional type tumors and non-functional. So before evaluating, we should have all these parameters for the evaluation of the NETs, like what is the grade of the tumor, differentiation, whether it is well differentiated, poorly differentiated, whether it is a functioning or non-functioning production based on the production of hormones, and from which site it is there, and has a malignant potential or a benign. And based on this, we have a lot of confusions now how to evaluate. So many investigations are there, which to apply for which patient. Like what are the biochemical markers for each site, or which imaging technology, EUS or a CT scanning or a functional scanning, when to use. So for this, with this introduction, this is my first case. He's a 52-year-old male who's been symptomatic for the past 6 months with GERD and dyspepsia symptoms. He came for us for endoscopic evaluation. It's a clinical diagnosis of a long-standing GERD, dyspepsia, and chronic constipation evaluation also. So further testing, routine blood investigations were within normal limits except for an hemoglobin A1C of 7.4. And colonoscopy was done, which showed multiple sessile polyps. Some of them were cold snaring done, and some of them hot scar polypectomy was done. So this is the endoscopic picture now. The panelists. Can I ask Dr. Vinod sir?
Endoscopy, I think in D1 we see two subepithelial lesions. Mucosa appear normal, so it looks like a subepithelial lesions. It can be anything like the differential diagnosis of subepithelial lesions include neuroendocrine tumors, can be a GIST or a pancreatic ectopic arrest, or even a lipoma. Like
okay, there are some endoscopic features of these. There are multiple subepithelial lesions ranging from some 5 mm to 1.5 mm. We see here in the duodenal bulb. So multiple lesions are there. So what will be your next step after an endoscopic?
Usually we take a biopsy.
So what is your strategy? Like you have a multiple of different sizes, and which to be biopsied and which to be left?
We take a bigger one first.
Yes.
If there's a central ulceration or punctation, we take it, we consider it from there. The biopsy technique, since the epithelium is normal, mucosa is normal, we tend to use something called a punch biopsy. If like take a biopsy at the same site where you have taken the previous biopsy. If the lesion is large, like maybe more than 1.5 centimeter, we can do a mucosal incision assisted biopsy. Like you just cut open the mucosa with a needle knife and take a punch biopsy from the deeper tissues. That can be useful.
So the smaller lesions, if we biopsy into biopsies, we usually create some submucosal fibrosis, and subsequent resections may be difficult. So you go for a standard biopsy now. So this is the biopsy we obtain pathologist. So those are the colonic polyps. The last one is the duodenal lesion biopsy. So we have a report of a neuroendocrine tumor from the pathologist. what are the classical features of neuroendocrine tumor? How would you say in biopsy? What are the classical features of NEN? And is there a grading system? Why the grading system is there? Then why is there the differentiation is so important? And what are the mitotic indices? And what is that Ki-67? Why both are used? Like mitotic index and Ki-67, does it have a role in the management?
See, pathognomonic feature, as you can see in this picture, is a organoid pattern, which is very easy to recognize for any pathologist. So to be an organoid, it's a nest. So you can see nests of these cells. And next slide. You can see the nucleus. Actually, if you put it in a high power, classically as a salt and pepper chromatin. So if you have this organoid pattern with a salt and pepper chromatin, it's clear that we are dealing with a neuroendocrine neoplasm. And it's very easy to recognize histopathologically, microscopically. But we don't stop there, we need to grade it. Grading can be done using mitosis or with Ki-67 index. So mitosis is the one which can be recognized microscopically itself. You need thin sections for it. So you need a good section for it, and then we can but Ki-67, since it stains differently, brown color in the background of blue, it is very easy to recognize that. And the advantage of using Ki-67 is it can recognize two cells which are even in the dividing phase. So in a mitosis, only if it is in the last M phase, you can detect. Whereas if the cell enters the cell cycle itself, the dividing phase, Ki-67 can easily pick up. So Ki-67 has an advantage of over the regular mitosis. But even then the number remains the same, which is 2 to 20% for all the gradings of grade 1 and grade 2, grade 3 tumors.
Okay. So this is what we have got the histopathological report with the immunohistochemistry of these one duodenal lesion.
Among the IHC markers, classically used is synaptophysin and chromogranin. Everyone would have come across. But the newer one is the INSM1, which is the insulinoma associated protein 1. So the advantage of insulinoma associated protein 1 is it is a nuclear marker. So whenever we have a cytoplasmic or a nuclear marker, IHC, we tend to use nuclear marker because that is more specific. So INSM1 is little more specific than the synaptophysin and chromogranin. So sometimes instead of using 3 or 4, we can try at least with one INSM1. That will be easier for the patient also. So you can see there in the picture, the first picture is the INSM1 on a carcinoid, which is a grade 1. You can see almost all the cells have taken up. Whereas when it becomes malignant, the number of cells which is taking has come down. And the intensity is also varying. One is dark brown, one it is little lighter one. So these pictures tell us that we are dealing with a higher grade tumors rather than a low grade tumor. So INSM1 indirectly also, it's a soft sign, can also tell us that we are dealing with a high grade tumor.
So when there is well differentiated, the risk of metastasis is less. Like, okay. So what are some additional biochemical tests to confirm the neuroendocrine tumors, and what is its role here in the duodenal NETs?
We usually ask for a chromogranin, serum chromogranin estimation. So, I mean, as it's put up, it's like it can be falsely positive when the patient is on PPI use or in renal insufficiency. Or
so we have to stop the PPI before testing it.
Asking for a serum chromogranin.
So it's less sensitive, and here's one study I came across is that it has a predictive role. The base level chromogranin A has a very high predictive indicator for the overall survival, and considering the stage, grade of the tumor, sex, and the functioning tumors also. So it has a role in for the course of the treatment also.
And one
So
more thing for chromogranin, it can vary upon the day also. In the morning it can be little high, in the evening it can be little low, so you have to be very careful interpreting those cells.
So what is the ideal time to then send?
So there's a diurnal variation you should keep in mind.
Okay.
When it is high, you take it. When it is low, you cannot rely
What is
on
the cutoff, sir, to take? If it is normal, from normal range it is there any grade like that?
exactly remember the cutoff I have to say.
Okay, if it is positive means it is more than the normal value, it considers okay. So additional biochemical markers, if you suspect any specific syndromes, you can have a classical clinical syndromes. Based on that, you can order the additional biochemical markers, especially the pancreatic neuronic control. For this patient, we have the chromogranin A level, which is elevated than the normal, and the serum gastrin level was normal. So next step, so we have a multiple small tumor, NET suspected there, proven grade 1 NET, then which imaging modality will prefer now?
If we suspect an NET, we usually ask for a Dotonex scan. Rather than FDG PET, we ask for a Dotonex.
And what you would prefer, ma'am?
See, once you have a pathology as NET, the one-stop shop image should be gallium dotatate. When
No-
you have a
no
well
role of CT or
differentiated-
MRI,
Yes, because
yeah.
you have the whole body CT in that. So it's two modalities combined together. So that is one-stop shop.
Is there any role
But
of
if you, as I have already discussed, the key, according to the key index, if it is in the gray zone of anywhere between 20 to more than 50, like that, then you have to have both the imaging, both gallium as
And the
well as whole body FDG PET
MD
CT.
PET? Okay, it's a well
So you
differentiated
don't go
grade.
now separately for conventional CT or conventional MRI, but after doing gallium dotatate, for seeing very minute liver metastasis, maybe you can use a MRI in fusion with PET.
Okay. So this is all incidentally detected now in our case. So how far you can evaluate them? So telling them, finding a small size of NETs, when you tell the patients, then repeated imagings, then they lose hope also. So we have to tell them, even if it is small, it can be a metastatic, locally advanced or a metastatic disease. So for this patient, we directly gone for the gallium dotatate PET CT. So we have a localized uptake only, the duodenal nodule. So multiple nodules were there, but surprisingly only one nodule they have mentioned, it is uptake. So which is a nodule also we don't know. So why is this happening when so many nodules are there, only one nodule is picked up?
The expression of the somatostatin receptor can be different. Not necessarily all the tumor cells have to express same number of receptors. Number one. And when you see a gallium dotatate, what you are seeing in the middle, we have to remember that uncinate process of the pancreas will show normally a physiological uptake. One has to be very careful about it, because when you are looking for only 0.5 and 1 centimeter size, looking out for any other, you should not mistake that as a tumor. Physiologically, it is expressed in the uncinate process of the pancreas.
Okay. Then we do have some inflammatory uptake like dotatate there.
There again, see these gallium dotatate, NAC, everything, as I have already told, the receptors expression, it can be 2, 3 or 2, 3, 5 or it can be 3. So it depends on which radiopharmaceutical you are using. Apart from that, this sensitivity, specificity, negative predictive value, everything is more than 95% for this. But always there is this less than 5% is there, anywhere between 2 to 3%. Some of the inflammatory markers may take up. For that we have to use a CT aspect of it and the clinical and other biochemical aspects to know whether it is inflammatory. In that case you have to follow it up.
Okay. So is there any role of US in staging?
Yeah, definitely. If you are, if there is a submucous lesion, doing an US will tell you from which layer it's arise from. If you are not convinced on an, endoscopy, NET can arise from layer 2 and layer 4 of, musculus propria or musculus mucosa, and it can also, tells about the loco-regional lymph nodes, whether it has spread to the loco-regional lymph nodes. More than that, we can take a, F and B from this US. You can see the liver closely, and if there is any lesions, it can also pick up with any US.
So if you are planning for an endoscopic resection, so you should proceed first with a diagnostic US and assess the layer of involvement. Second and third layer is the most common for an NETs to present, and the depth of invasion, lymph node invasions, everything. And for biopsies, sometimes when endoscopic biopsies are negative, we can also, if the size depends upon the layer, we can choose the type of biopsies. Like second and third layer, we can do a normal biopsies. When it is deeper located, then you can use FNB or FNA can be attempted. So, in later ESG guidelines also say it is US is the best tool to characterize and subepithelial lesions. And if the lesion is more than 2 centimeter, you can either use an US FNB or a mucosal incision assisted biopsies for these lesions. This is our case. It is limited to the submucosa of 1 centimeter size lesion there. So, and complete evaluation of the NET should follow this protocol. It should, whether it is a sporadic or a syndrome associated inherited syndromes, whether single or multiple, what is the size of the lesion, whether it is functional or non-functional. So, in our case, it is a sporadic case, incidentally detected multiple lesions, non-functional, it is a non-ampullary type duodenal lesions of a very well differentiated grade 1 tumor, which is localized with the dotted COVID without any regional lymph nodal metastasis. So, what will be your treatment options now? You will wait and watch, or follow up with repeat endoscopic screening protocol, or you will go ahead with any endoscopic procedures or surgery.
We have to speak to the patient regarding all these things. Wait and watch can be done. Since it's 1 to 2 centimeter, I prefer to remove endoscopically. Since the facilities nowadays, endoscopic options are that much. We can do an EST or even EFTR. It can be done easily. So we have to offer this treatment options to the patient.
Yes, sir. Okay, there is difference between an ampullary NETs and a non-ampullary NETs that we should all, the ampullary NETs behave differently from the non-ampullary duodenal nets. So, they mostly present with symptomatic jaundice because of the involvement of the biliary tract, and even a small size lesions can easily metastasize. In that case, ampullary tumors, endoscopic resection is not the choice. Then those patients should undergo surgical procedure. So, the guideline like less than 1 centimeter confined within mucosa and submucosa, endoscopic resections can be safely attempted. 1 to 2 centimeters, still again endoscopic resection is the choice and depends upon the type of the endoscopic resection techniques. And if it is more than 2 centimeter with or without any lymph node metastasis, then surgery would be the ideal option. And in ampullary NET is always surgical intervention. So, among the endoscopic options, what is your choice in this case? Said an EMR, ESD.
Choice depends on the location of the tumor.
So in our case, it is mostly in the limited to the submucosa, and the size is 1 to 2 centimeter. The largest is 1 to 2 centimeter.
I'm not a firm favorite of this band ligation without resection, since the band can slip out at any time. So my preference will be an endoscopic submucosal dissection. And even more that the EFTR we have done for few patients, and it's not time consuming, we can finish it in. So my preference will be in EFTR or in ESD.
So EFTR has its own advantages and disadvantages. Like if it is limited to only mucosa and submucosa, why you want to go for an EFTR, which is all layers like. So it is limited to mucosa and submucosa, and it is very small.
The chance of perforation in duodenal NET with ESD is more. In fact, it's on the medial wall. When we try to do an ESD, the chance of perforation will be higher. So instead of doing an ESD, I prefer to do an EFTR if it's on the proximal side, not on the distal end. If it's on the proximal end. Okay.
So what we did in this case is a banding without resection technique. So as Sir said, it's difficult in a normal mucosa to get that thing. So what we need to do is adequate submucosal injection should be given to lift the tumor and see for the lifting sign. So if the lifting sign is there, then adequately you have lifted the tumor from the submucosa, then it is always easy, and suctioning is very important, and tight suctioning should be there to get into the distal hood with the band apparatus. So this has been currently approved, and it has been practiced since 2017. The FDA has also approved, and many of these small lesions can easily be dealt by band application without resection. That is EMR we are not doing. But once after the biopsy proven NETs we can do. So before that we can't just go and put a band and come, because we will be missing the histological diagnosis. So in a well differentiated tumor of grade 1, 2 and limited to mucosa submucosa of a size of around 1 centimeter or to 1.5 centimeter, we can safely do this endoscopic band ligation without resection. So this is what we just inject at the submucosa and lift the tumor, just put a ligation band. So this is one of our case where this is the lesion after this is a follow-up endoscopy showing only a scar left. Even that scar has to be inspected for any residual lesions or new lesions. So this is a second case. She is a 46-year female admitted with multiple times she has been admitted elsewhere, and this time she came with an hematemesis and melena, and on examination she's pallor and tachycardia was there. Hemoglobin significantly dropped to 7.2. So she had a multiple past history. She had multiple operations. So Wilms tumor, she was operated. She is a single kidney now, and multiple surgeries has been already done, like appendectomy, hysterectomy, everything. So in 2014, she presented with similar bleeding, UGI bleed, for which she was extensively evaluated with OGD colonoscopy and capsule endoscopy, and they noted multiple gastric polyps, miniaturous polypoid disease-like, and there were small bowel erosions and ulcers with mild narrowing at the D3 junction. And they evaluated, and finally Cori small bowel Crohn's disease, she was put on, she was not willing for azathioprine, and they put on Pentasa. She has been on Pentasa since then. So 2018 again she had similar episodes of bleeding and managed conservatively. She last to follow up after April 2021. So this is the endoscopic picture now. In stomach you have a multiple polypoidal lesions, and in the bulb D2 multiple submucosal to mucosal involvement is there, and D3 we have a stricture D3. So the duodenal biopsies D2 lesions, the duodenal biopsies came as a neuroendocrine tumor of grade 1. So next we proceeded with the Dotatak PET CT, and it's a biopsy proven case, and we do have lesion in the D2 part, and also we have a periduodenal lymph node positivity and a gastric lymph node positivity in the PET CT. So this case is a sporadic case, multiple less than 2 centimeter, non-functional type. We don't know the reason for the bleed. So she presented with bleed, but bleeding from these lesions are unlikely, and non-ampullary type duodenal of a grade 2 NET by biopsy, Dotatak avid primary lesions, and also we have a Dotatak avid duodenal and distant gastric lymph nodal metastasis, and no hepatic metastasis. So what would be your options now? In the background of thin-built lady, multiple surgeries already undergone, single kidney, and is there any role of endoscopy, or will you subject her for surgery? Any role for hormonal therapies now, considering the background, or when you prefer a PRRT, or directly go for chemotherapy?
So
surgeon's role?
Yeah, so here we have a lady who has a well-differentiated lesion. The grade is early, so, and there is a lymph nodal disease which has been picked up on the imaging. So the option of surgery would be the first option, considering that it can offer a safe cure, and apart from the fact that she's had previous surgery, she appears to be a good candidate fit for surgery. If she was not fit for surgery, then we would look for other options. The challenge here would be that she also has multiple stomach lesions, and since she has presented with a GI bleed, what is the extent of surgery? That is the only challenge here. That would have to be discussed with the endoscopist and decide the extent of surgery. and the diurnal resection, whether it would amount to a Whipple's or not. So in that case, we have to decide whether you would like to add a subtotal gastrectomy or do a limited resection of that and keep that under surveillance. Obviously, this is multiple gastric lesions, so there is a component of gastrinoma probably, or a gastric
But that
carcinoid.
repeated biopsies of the stomach polyps, no, it always came as hyperplastic polyp. It didn't turn anything.
Yeah. So one option would be to keep her on a PPI long-term therapy and maintain and treat the diurnal lesion with surgery.
Is there any role for octreotide therapy? Medical oncologist, sir?
First line of treatment will be the surgery because it's localized. So only if the surgeon seems it's unfit for surgery, medical management comes. So I will go for octreotide first.
Okay.
Unless it is inoperable.
So this is a possible algorithm we can have in the NET management. As I already said, it's a grade 1 to 2 tumors, and if it is localized, then endoscopic resection or surgical resection would be a better thing. And if it is a progressive symptomatic disease, when there is a DOTA uptake is there, initially we plan with octreotide therapies, then assess the disease progression or response. Based on that, and subsequent therapy can be done. This is another case, multiple comorbid conditions, and she was having a long-term PPA use for her GERD and dyspeptic symptoms. Investigation-wise, macrocytic anemia with B12 deficiency is there. This is the endoscopic picture.
It's a subepithelial lesion in body of stomach with central ulceration. If you look at the third picture, probably with a central ulceration. Can be an NET.
Okay. So when we are evaluating for a gastric NETs, our focus should also be around the surrounding mucosa also. So
Atrophic
the mucosa
gastritis.
appeared atrophic here,
Atrophic gastritis.
without the gastric folds are effaced, and we say nothing, no gastric folds have been there. So multiple subepithelial lesions with some ulcerations, a few lesions are there, and while biopsying these type of lesions, we should follow the Sydney protocol also. You have to rule out H. pylori infections, and for atrophic gastritis, we need to take biopsies from antrum, body. Also, we should take along with the biopsies from the suspicious lesions also. So this should be a take-home point. So this is the biopsy from the subepithelial lesions, and grade 1 NET it came. So is there any difference in diurnal NETs and gastric NETs? What are the types of gastric and how do you classify these gastric NETs?
Gastric NETs are of 3 types, type 1, type 2, type 3. More common is type 1. Type 3, type 1 and type 2 is associated with increased gastrin levels, whereas type 3 is not associated with increased gastrin levels. Type 3 has a worse prognosis than type 1 and type 2. Type 1 is associated with chronic atrophic gastritis.
Okay, the risk of metastasis is very rare, and very good prognosis there with the grade, type 1 tumors. Type 2 tumors are associated with MEN syndromes or gastrinomas, where you have a high level of gastrin and hyperacidity. So in our case, the fasting serum gastrin level was elevated and chromogranin A was elevated.
Polycythemia was also regarding the government. I would like to know, since 1998, what are the major
Nearby.
policies
Okay.
relating to the real estate? What have you achieved? And what are the
Somewhere outside. So we proceeded with the DOTA-TAC when PET-CT. So there was no uptake in any of the lesions by DOTA-TAC. Instead of that, there is an uptake in the gastric antrum, as already Madam has mentioned, that inflammatory type. So we don't have any uptake in the gastric lesions. But we have a histological diagnosis of an NET, a well differentiated grade 1, but we don't have any uptake here. So this is a case of sporadic, not an associated with. So we have multiple lesions of 1 to 1.5 centimeter maximum. A non-functional type 1 gastric NET of grade 1, non-DOTA-TAC COVID without any regional lymph node metastasis. Again, what would be your options?
endoscopic band and cut or treat in watch.
Okay. So multiple lesions, the same sitting, multiple bands can be applied with the same technique. All the lesions can easily be tackled with the endoscopic band ligation without resection technique. So another case, this is a elderly woman. She was evaluated for generalized weakness and malaise in 2017. So abdominal imaging showed a suspicious area in the head of the pancreas with secondary hepatic lesions. She came with a ultrasound guided liver biopsy. Liver biopsy from the SOLs and the immunohistochemistry confirming the diagnosis of a metastatic neuroendocrine tumor with intermediate grade of grade 2 with a Ki-67 index of 10%. And DOTA scan also showed an overexpression of the somatostatin receptors. So this is a case of metastasized pancreatic neuroendocrine tumor of grade 2. So what will be medical oncologist, sir? I think I borrowed this case from your. So I think you are following this case since 2017.
Yes.
So what will be the first modality how to treat? So first I will ask the surgeon, is there any role for surgery now? So you have a hepatic lesion and pancreatic mass.
So if there is limited metastasis to the liver, one can consider the role of surgery or combining surgery for the primary and liver directed options. However, in this case, there is extra hepatic disease. You have a disease going on to the bone. So therefore, the treatment approach is now more towards the ball is going to be in the court of the medical oncologist, and probably there will be a role of nuclear medicine, and we'll sit together and decide what is better. And then at some point, if there is a very good response, one would think about it, because still it is grade 2.
Why not we directly go for
I think
PRRT?
even as an endoscopist, we have an option for this. We can even do an radio frequency ablation of the pancreatic lesion. That can be a palliative option.
Okay. What is your take on that, sir?
No, she was generalized malaise only. She don't have any
Major symptoms.
major symptoms.
So at this stage, you will begin with a somatostatin receptor analog since it is positive. So as you have started this patient with a depot injection of octreotide 30 milligram IM injection for 28 days, and she well tolerated without major toxicities, and it was stable until 4 years. So progression-free survival up to 4 years she has been kept. What is the cost of this octreotide injection? How they are able to afford for so long and the therapy? And it seems more promising that you have prolonged her survival, hepatic metastasis from 2017 to 2023. So we would like to, because as gastroenterologists, after this point, we just refer to a medical oncologist. When we never follow them, maybe they are more attached to you. So we want to know what will be the cost of these therapies, like octreotide, depot injections, which is safe, lanreotide or an octreotide.
Lanreotide is only available in West. We don't have it in India. We have to import separately. And commonly we use octreotide only. 30 milligrams is the usual dose. If they are not tolerating, we switch over to 20 milligram. And the cost also differs slightly between 20 milligram and 30 milligram. If they are affordable, we start with 30 milligram, which is a standard dosage used in most of the trials.
Okay.
Lanreotide we don't use routinely as of now. So for this patient, we do, for a pancreatic neuroendocrine tumor, we don't have a very sequence evidence which should be given first, which should be next, which should be third line. We don't have any evidence for how to sequence. So why I chose this SSA is it's very less side effects first of all, and we have a very good uptake in the Totonac. And definitely we can have a good quality of life also if the symptom reduces. And we will come to know how the tumor behaves by giving these SSAs. Most of them, they do well whenever the Ki-67 is up to 10%.
In this case, we have seen like up to 4 years, she has been on only this octreotide. Okay. So in Jan 2021, she returned with the disease progression with a large hepatic lesions. Then she was started on everolimus 10 milligram orally once a day. What was your choice of choosing this everolimus as the second line now, when she is not? Yeah.
We don't have a evidence which should be given first. Even
Or we
everolimus
can
is
increase the dose of octreotide and see, or this is the maximum dose of octreotide, since he has
generally we
responded.
give 30 milligram only. So if they're not responding, we switch over to the next line. If
Okay.
the lesion is increasing, a stable disease we take it as, because we don't expect the tumor to regress most of the time. It will be stable disease, and patient will be symptom free. That is what we expect at the maximum.
Is there any difference, ma'am, for PRRT, like already experienced these line of medications and then refer to a PRRT? Is there any difference in the survival or benefit of PRRT after this therapies?
Usually the first line goes with the medical oncologist, they try all that. And again, it involves personalized as well as pathology oriented, which great, and the affordability, everything. But without going for the initial medical oncologist, the regular long acting octreotide, normally we don't go in for this. But the symptom is very high, hepatic load is very high, then in that case, PRRT would be better than the.
Okay. So this everolimus, she had some pulmonary toxicity and mucositis, and clinical response was there, and the hepatic lesion showed some reduction in the size, and she was being kept in everolimus for 1.5 years. So further, July 2022, she had an again increase in the size of the hepatic lesions and with the local disease activity. So she was started on sunitinib now.
Generally,
So-
the second line drugs are very toxic, first of all. Fortunately, she tolerated very well. Everolimus, they have a very severe mucositis. Most of the time, we have to reduce the dose by to 5 milligram OD. Even 10 milligram, most of the people, they don't tolerate. But fortunately, she was doing well because we are giving a monotherapy for her. And even the sunitinib it is very, very toxic. Most of the time, they have a severe mucositis.
Yes, sir. So again, she had progression of the disease, and the fourth line, capecitabine and temozolomide. What is this newer drug, temozolomide?
No, it was already
Temozolomide.
existing only. It's alkylating agent. It is used for glioblastoma multiforme usually. And we have evidence with this single agent capecitabine versus capecitabine and temozolomide. And it was doing well because as line progresses, we think in favor of more K67. Ideally, we have to do repeat biopsy and see the nature of the disease. And for her, we did repeat biopsy and it was showing around 40% K67. And she was tolerated on chemotherapy.
So she had already 10 cycles already done, and stable disease, regular. Okay. So this is another case where she was evaluated for recurrent vague abdominal pain and recurrent subaqueous intestinal obstruction. So in 2022, she was suspected to have a distal ileal carcinoid and subsequently underwent a DOTA tech. And we have a ileal carcinoid with adjacent mesenteric nodules which are non-functioning. So she had only tumor-related symptoms of recurrent SAIO. So what will be the management surgery? Is there any difference in the surgical management of managing these carcinoids which with the mesenteric this thing? While handling the tissue, is there any chance of release of hormones and any precautions for that prior to handling these kind of aggressive tumors with the production of hormones?
So prior to surgery, if we are already aware that these are functioning, we always try to see that they have been appropriately treated with octreotide, and then they are taken up for surgery, so that while we handle, it doesn't cause any catastrophic release of hormones. Secondly, the other things that we have to keep in mind, as Madam pointed out many times, you will have synchronous lesions, so which may or may not be picked up by imaging. So during surgery, a careful exploration to look for any synchronous lesions. In case the facility is available, intraoperative ultrasound is very useful, especially to look for any metastasis in the liver, the extent of the metastasis if it is already known that they are there. And there will be a fair amount of mesenteric fibrosis which is there, so which will make surgery a little difficult, and the local lymphadenectomy, that is where we have to take the entire mesentery, so that is going to be a little challenging. We have to make sure that we excise the entire mesenteric this thing. And in patients in whom we are contemplating octreotide therapy in future as well, especially in high-grade tumors, it is important that we consider a concomitant cholecystectomy because of octreotide, they will be at high risk for developing gallstones and also cholecystitis. So in case you are opting for surgery, it's important to consider adding a cholecystectomy in such patients.
Okay, so we did a laparoscopic assisted segmental ileal resections in this case. So coming to the end of the panel discussion, so once an NEN is been diagnosed and there are so many parameters you should take into consideration regarding the grading of tumor and the differentiation of the tumor, functional or non-functional extent of the disease, TNM staging should be done, and the performance status of the patient. So, and based on the site, specific therapies can be initiated. So, it is actually a multidisciplinary team management for the NETs. So, I thank all the panelists for their valuable time and giving valuable inputs. And so, with this, we conclude this panel discussion.
Nicely done, Satyamurthy.
Thanks.
And if there are any queries from the floor? Yes, Tayu.
Shows that probably there is nothing. In fact, the case that I had did not even show a scar. Now, how do you follow this up?
So, following these patients, generally the grade of the tumor and adequately resected and repeat endoscopy didn't find any findings. In duodenal, we don't need follow-up after that. So, when it is a gastric type 1 NETs, we need to follow because they are more prone for this atrophic gastritis related this thing. So 1 to 2 years repeat endoscopy has to be done, assess for the newer lesions because they are hypergastrinemia and chronic atrophic gastritis follow-up should be there.
For duodenal NETs, you don't need to have a repeat dot of PET CT or something 1 year later, nothing?
No, sir, not required. If you are endoscopically adequately resected, there is no.
I think if it would be pertinent if you can at least follow them endoscopically for some time because we don't have standard.
Depends on the size of the tumor also. If it is more than 2, you need a follow-up.
So akin to adenocarcinoma, we don't have standard protocols for neuroendocrine. So till such time that we have data, it's good to do at least a yearly endoscopy and have a look. And if you find something, then you can always do something about it. Imaging may be a difficult proposition to do because of the cost involved and other things. But if you've seen it yearly for 2 to 3 years, and after that probably you can keep them on, just follow based on the clinical presentation.
Okay.
Thank you, Doctor.
Thanks.
Thank you, panelists. Thank you, Satyamurthy, for that good panel discussion.
Thank you, sir. Thank you, chairpersons. It's my honor to thank the chairpersons and moderator and the panelists for taking part in this wonderful panel discussion. I'll request the chairpersons, Dr. Ganesh and Dr. Malaruri, to stay back and honor our guests who have come from other departments to spare time with us and educate us about their use. I'll request Dr. Malaruri to honor Dr. Indrani. Please, madam, just short. Please come on. Thank you, madam. Listening. Thank you so much, ma'am.
Just take this.
Sure.
And there was one pointers.
Thank you. Thank you, ma'am. I'll request Dr. Ganesh to honor Dr. Sivasubramaniam and Dr. Shushrudan for sparing time with us and taking part in this, making this panel discussion quite useful. Dr. Shushrudan, please. Thank you, sir. Now I request the chairpersons to hand over the certificates to our postgraduates who did a good job of presenting their cases. I call upon Dr. Nitin Ramesh. Request Madam to present this. Dr. Shrujan. Okay. Dr. Anna. Dr. Dino Birami. Thank you. Thank all the members for coming over. And I'll thank support from the pharma group, particularly Abbott, Delvin, and Fords for sponsoring this meeting. And I request all of you to join for dinner and fellowship. Thank you.